Welcome everyone, and if you have specific questions for Jamie on the topic, feel free to put them in chat, and we will also have time in the breakout rooms for questions to be gathered, and it will be very interactive. We do have Kristen Chatfield, because we do have some Oregon specific data that we've integrated into hey, Kristen, into Jamie's presentation to make this as very applicable for all of you. So with that, Laura, if you want to take it away, and I will make sure everyone's admitted into the room and problem solve any access issues.
Sounds good. Well, I am so excited to introduce our speaker, who is Dr. Jamie Stang. Dr. Stang is an associate professor in the Division of Epidemiology and Community Health at the University of Minnesota School of Public Health. She also serves on the graduate faculties of Maternal and Child Health and Nutrition Science at the University of Minnesota. Jamie is the director of the Leadership Education and Training Program in Maternal and Child Health Nutrition and the MCH Center of Excellence at the University of Minnesota. Jamie was a member of the 2020 U.S. Dietary Guidelines for Americans Committee, serving on the Pregnancy and Lactation and Data Analysis and Food Pattern Modeling subcommittees. Prior to that, she served as a member of the Pregnancy Technical Expert Committee for the Dietary Guidelines, as well as the Committee for the National Academy of Medicine workshop on the current understanding of pre-pregnancy weight, gestational weight gain, and the impacts of maternal and child health, a workshop. Dr. Stang's research interests include the role of nutrition in the prevention of poor maternal fetal outcomes and in the prevention of obesity risk factors during early childhood, utilizing a positive deviance framework. All of her work is completed with a focus on the social determinants of health and nutrition and targets marginalized, underserved, and/or rural MCH populations. She has been an active member of many professional organizations, including the Association of State Public Health Nutritionists, the Commission on Dietetic Registration, and the Academy of Nutrition and Dietetics. In her spare time, I'm not sure how she has any, but in her spare time, Jamie is a master gardener who focuses on vegetable gardening, home food preservation, and habitat restoration for waterfowl and wildlife. So we're so excited to have Jamie talking to us about the dietary guidelines today. And with that, I will turn it over to her.
All right, thanks, Laura. I'm going to share my screen. So bear with me a moment here. Let's see. Too many things open at one time here. Okay, how does that look?
Great. That's good.
All right, great. So good afternoon, everyone. I'm really excited to be here. I worked in WIC at several points in my career in public health prior to becoming a faculty member. So it's always near and dear to my heart, and I love talking to people who work with WIC audiences. So today we're going to be talking about the dietary guidelines for Americans, and I'm going to focus mostly on the newest part of the dietary guidelines, which are the pregnancy and birth to 24-month sections. Looking for my page down here, but it's, oh, there we go. So today we'll be talking about the dietary intake of infants, children. I'll touch a little bit on adolescents since you sometimes work with adolescent mothers, and we'll talk about pregnant women. We'll discuss some of the nutrients of public health concern and of special consideration for maternal and child populations. We'll talk just a little bit about the new food plan for the 12 to 23-month-olds, and then highlights of some of the recommendations. And so I'll start by talking about breastfeeding initiation and duration. And essentially, this is data that came from the National Immunization Survey. It's a couple of years old because the way that the lag is for data collection. And quite frankly, we're going to be working with old data for a while because NHANES data collection was stopped during the pandemic. And so we're going to need to get used to having data a few years old, at least for the coming years. But if you look at national data, what you see is just about 84% of new mothers initiate breastfeeding. About half to 60% are still breastfeeding at 6 months of age, their infants, and then about a third of the 12-month-old infants are still being breastfed. However, when you look at exclusive breastfeeding, it's less than 50% are exclusively breastfed at 3 months, and just about a quarter are exclusively breastfed at 6 months. And then now this is again national data. When you look at the national data and you look across racial and ethnic groups, you do see some differences in that Asian and white women have the highest rates and Black women have the lowest rates. Now, what I will say is we use very broad categories in these kinds of national data. If you actually start breaking them down further, what you will find is, so for instance, in my state of Minnesota, our Somali population actually has the highest initiation rate. They fall in the Black category. Our Hmong women actually have the lowest rates of initiation, and they fall in the Asian category. So just do keep in mind that these data can guide us, but we really need to try to take the time to delve into different subpopulations within these broad categories, because there could be some big differences. And again, you see differences in breastfeeding at 6 months and at 12 months by racial and ethnic background. When you look at exclusive breastfeeding, you see similar data. The exception is that white women tend to have higher exclusive breastfeeding rates at 3 months of age comparatively. And that is just the one difference we see here. Now I'll turn it over to Kristen if she wants to talk a little bit about the breastfeeding rates in Oregon specifically.
Sure. Yeah, it's exciting, of course, in our population, and one of our missions is breastfeeding promotion. And one of the ways that we see that is look at our initiation rates for the past few years. Really solid, steady, right about 95%. And it varies a little bit by agency, but not much. It stays pretty high. We have a really high initiation rate. But you'll notice the numbers do drop off a bit. And, I think some of that is specific to our population. There are certainly barriers to continuing to breastfeed at work. Are you keeping up your supply? Do you have a safe pumping space? Yes, we have laws and policies that supposedly set us up to do that. And yet having a law and a policy written down is different than potentially having to pump in the bathroom if you're in food service or something. So we do see a bit of a drop off, and I do have a little bit of data that I've started to look at from Washington County. I haven't looked at this recently statewide, but we tend to see Hispanic mothers breastfeeding with longer duration and longer duration of exclusivity, more so than our non-Hispanic mothers. Anything else, I can kind of poke around at it. I don't want to take too much time.
All right. Well, we will have a chance in the discussion sessions to talk a little bit about this. So if there are questions, maybe we can have people write them down during that session, Kristen.
Fabulous, yes.
Okay, thanks. So I will move on. Let's see here. Doesn't want to go down again. Oh, there we are. All right, so I do want to just make sure that I'm in the right place to talk a little bit then about the dietary intakes from birth to 24 months of age. And we just talked about the breastfeeding rate. So we'll talk about some of the other data. And one of the things that was relatively new for the Dietary Guidelines Subcommittee was to look at the timing and introduction of complementary foods and beverages. And you can see from this data, again, this is national data, that just under a third of infants were under the age of 4 months were receiving some type of solid food, most generally cereal. about half of 4 to 6 month olds. And then there were about 20% of the children who received their first solid foods after the age of 6 months of age. Now, what we were not able to get out of the survey, because they don't actually ask the question, is among those that were under the age of 4 months old, how many of those were medically warranted because of something like gastroesophageal reflux, and they were told to put cereal in a bottle or to feed the child cereal, as opposed to mothers who are just starting that. And that's one of the big gaps in the national data sets, is that that question has not been asked. And we do recommend that they start asking that within the survey so we can make better sense of that data. Now, one of the more interesting things I think that we were able to do within the B24 committee was to look at initiation of solid foods and beverages under the age of 4 months by the type of milk feeding they were receiving. And what was very interesting is we found that when you look at the infant formula only compared to human milk only, we see a huge difference. More than twice as many of the infant formula only infants were receiving complementary foods and beverages at a very young age compared to the ones who were receiving only human milk. So then it made us start to think, well, maybe there's some other differences. And actually, and I don't see that data there, so I will have to back up. There are some data where we actually were able to look at the sources of food and beverage for 6 to 12 month olds by whether they were fed human milk or not. And I just realized that those slides are not in here, but I'm more than happy to talk a little bit about that a little bit later. We did find some big differences in how, and what we found is that infants who are fed only human milk tend to get fewer of their calories from sugar and solid fats. They tend to get more of their vegetables and their meat from food as opposed to commercial baby foods. And so these were data that never actually made it into the final dietary guidelines, but they're data that are were included as part of the analyses that we ran on the subcommittee. What we did look at also is we wanted to sort of track the intake of food groups by age in these under 2-year-olds, because that had never been done as part of the dietary guidelines process. And I've highlighted here some of the things that I think were most interesting. And that is, if you look at vegetable intake from 6 months to 5 years of age, we really don't see much of an increase, despite the fact that the calorie needs increase significantly, food intake overall increases. Vegetables really do not, when we're talking 0.1 cup, that, we're talking less than a tablespoon difference. So vegetables, at no time do we ever meet vegetable recommendations, and they really don't improve with age. We do see that oil intake, and if you look, 6 to 11 months olds not getting a whole lot, jumps up significantly by the time they're 2 years of age. But then look at what happens between 2 and 5 years of age. They double again. So both solid fats and oil have this really big shift between the 12 and the 23-month age range. And you see something similar for sugar. You see very, very small sugar intake in that under 12-month age group. By the time they get to 12 to 23 months, we're seeing about 6 times the amount of sugar, and then it doubles again in the next couple of years. So these are just some of the trends that we have recommended that some of the national surveys continue to look at, and that this really seems to hone in on the fact that we were really trying to encourage future committees to look at that under 24 month of age, particularly that transition from largely milk-based feedings to solid food feeding. So let's talk just a little bit more about some of the dietary intakes. And this is all age groups, and then I'll a little bit later pull out the younger children and the pregnant women. So if you look at the American diet, the way that the Healthy Eating Index score is it looks at about a dozen components of food categories. Some you want more of, like fruits and vegetables. Some you want less of, like sodium or solid fat. It scores at 0 to 100. So 100 would be an ideal diet, 0, pretty much ho-hos and ding-dongs. And 59 is where the US population falls as a whole. If you look to the right of this slide, what you'll see is at either end of the age span or our lifespan is where we really see the best scores. We see that children age 2 to 5 have an average score of about 61, and those that are 65 and older have an average score of 64. And our lowest scores really are in that 6 to 17 year age range. Again, not a huge difference, but we do see that diet is not particularly strong in terms of quality in children, and that as we age, it goes up a bit. Now, I will show you some. For the first time, we ran HEI scores on pregnant women, and I'll show that to you in a minute. And I will just say that we did not have time on this round to run an HEI score on the data for kids that are 12 to 24 months of age. The sort of composite data that we looked at, it wasn't a final score, shows that it probably is a little bit higher than that 2 to 5 year age range. So it's probably somewhere in the mid 60s, but we didn't get a final score calculated. And so when you look at vegetable intake, as I said, there's no period of time in our lifespan where the US population tends to get enough vegetables. So what you see on the next couple of slides is males are on the left and females are on the right. The kind of purplish red dots are where our average intake is for a population. And then the blue bars are what the recommendation is. If you look at fruit intake, what you see, again, the 2 to 5 year olds are the only time in the lifespan where we meet fruit intake recommendations, and then it drops off and it pretty much stays level and low throughout the rest of the life. And here, let's see, what are we looking at here? It's all covered up. Guessing this just by looking at it is probably protein.
It's grains, Jamie.
Oh, it's grains. Okay, thank you. Grains. So this is what we see here is that females are actually decreasing their grain intake at a young age, at the young adult age. So as they get older, the 70 and olders are actually meeting the recommendations. But interestingly enough, females are actually below the grain intake that's recommended. However, when they're young females, they tend to be higher. And then when you look at dairy intake, we barely meet the recommendations in that 2 to 5 year age range, and it drops off from there. Now, the one thing I will say that's important to note here is when they calculate the dairy score, dairy includes cow's milk and soy milk. It does not include any of the other milk substitutes because from a macronutrient like having adequate protein, even if it's fortified, the protein levels of things like oat milk, hemp milk, nut milks are just too low to be considered comparable. So this does include any soy milk that children might be consuming, but it doesn't cover all of the other beverages. That is something that there is a growing amount of data in the databases at USDA to start to look at that. We didn't have enough data in the database that we had access to starting in 2018, 2019 to really look at that. So that's something I anticipate will be a big question in the next 5 years. And then when you look at protein intake, what you see is for the most part, males do, have adequate intake or above adequate intake. When you look at females, we have noticed in the last probably about, I want to say 6 to 8 years, a significant drop in protein intake in adolescent females. And so they actually, as a whole, do tend to have a pretty low intake of protein. And some of this is a little bit concerning, given that one of the major sources of iron in the diet is protein products. And so with females having a low intake and combined with the low intake of grain, which would be one of the major fortified sources, that iron deficiency is something that we're going to need to continue to monitor, particularly in those adolescent females. And so for the first time, they started to really look in NHANES at the 12 to 23 month olds. So we pulled out that data and made some comparisons. And as you can see here, so in those 12 to 23 month olds, average intakes are just below the recommended for total vegetables. They're above recommended for fruits, for total grains, for dairy, and then they're just at or below the total protein food intake. We weren't able to break this data down by race, ethnicity, or even gender, just because of the relatively small numbers we had. And then one of the questions that was first and foremost in our mind is, because vegetables are so low across the lifespan, what did that look like in the 12 to 23 month olds? And so you can see relatively low intake of total vegetables on the far left. Most of the categories looked pretty good. The exception were dark green vegetables, and then just a small percentage of the population met the beans, peas, and lentils. So in terms of, as we were thinking about what would be actionable guidelines or steps, one of the things that kept coming up was this need for the dark green vegetables in particular. And then how do we get children to maybe have some of those better plant forward based foods like lentils and peas and tofu and some of the other products. When you look at the 2 to 4 year olds, and again, this is the total vegetable, what you see is total vegetables are low for both males and females. Total fruits, they're right in there. This is the only time in the lifespan they'll meet that. Then you look at total grains, relatively high for males, okay for females. Dairy intake is low. Protein foods are okay for this group. Now, this is the first time that the subcommittee had ever specifically looked at data on pregnancy and lactation and done an HEI score. And so you can see that just as we have always thought, women do tend to eat better. They improve their diets when they're pregnant. So they go from an average HEI score of 54 for the typical adult woman to a 63, which is short of women that are 65 and older, is the highest score that we see in any group. And then lactating women are right up there at 62. So the good news is they are making some changes in their diets, and hopefully that's something we can build on. What we continue to see, though, is vegetable intake for both pregnant and lactating women being low, total fruit intake being low, total grains are okay, total dairy is low for both groups, and then protein foods, pregnant women tend to be right at the bottom level of the range, but they, as a rule, fall into that range. And lactating women actually tend to have a considerably higher protein intake. Then when we looked at pregnant and lactating women by vegetables, because that was a big focus of our group, what was interesting is, unlike children where dark green vegetables are the lowest, with pregnant and lactating women, that's actually the one category where they actually meet the recommendations. Where they are lowest are the red and orange and the starchy vegetables in particular. And then there's still a fair amount of work to be done when it comes to the beans, peas, and lentils. And then other vegetables, which are things like asparagus and beets and asparagus and cauliflower, things that don't really fit into the dark green or other categories. And then we did look at changes in food intake over time, because this kind of gives us an idea of what the trends are in food consumption and where we might want to put some of our effort in terms of the dietary guidelines. And I won't go through all of the categories, but what I will point out are the ones where we saw significant shifts. So we actually did see some interesting things going on in the grains and whole grains. In that, so if you look at the bars here, the darker colors are refined grains, and the darker orange and the dark purple is whole grains. And what you'll see is that while overall grain intake has gone down in most of the categories of age, except for those 6 to 11-year-olds where it stayed pretty stable, what's actually happened is a larger proportion of the grains are coming from whole grains. Now, it's not anywhere near the 50% that we would like to see people at, but we are seeing this bump up in whole grains. And I think I'll have some of the data a little bit later, but essentially we're seeing that in sandwich bread, and we're seeing that in some of the other whole grain products that tend to be like whole grain crackers and snack type foods. It's also one of the things we really wanted to look at, and the timing here was a little bit tricky, was whether or not the school mandates had made a difference. But obviously schools have been a little bit slower in rolling out some of those whole grain standards. But that is a question that I think the future dietary guidelines committees are interested in looking at, because there's some potentially interesting data there. And then when you look at dairy intake, what you see is that dairy intake has gone down in all age groups. And the only age group where it was actually statistically significant was the 2 to 5-year-olds. Now, just looking at the data, it looks like there has been some substitution of other types of plant-based milk substitutes for cow's milk or soy milk, but we actually didn't have an adequate type or amount of data to really say that for sure. But that is definitely one of the questions that we're interested in having future committees look at. And then when you look at total protein intake, again, it's been pretty stable with the exception of that adolescent female group, where we've seen a drop off in the last decade or 15 years in protein intake in that particular group. Then the good news is that, so in this graph, you see that green is solid fats and the blue are added sugars, is that both total fat and added sugar intake have gone down in almost every age group across the board. But the place where we still need to do a little bit more work is the fact that, so if you look at the green, the green is the solid fat. So we really want to see 10% or less of calories from total or from solid fats. We've still got a long way to go there. And the blue bars, which are sugar, again, we still need to get that down. Now, one of the things that I think being on the committee was great and the whole process was great. I think our biggest disappointment as a committee as a whole, and I would say as individual members, was the fact that the data that we pulled, and if you look at the scientific community report, we recommended no more than 6% of calories from added sugar, because that is really where the data fell. And for a whole variety of reasons that I may or may not fully understand, the USDA and HHS decided to keep that at the 10% threshold. Part of that may be because we haven't even come close to meeting that yet. And they thought that setting the bar was too low. But quite frankly, I think that was a little disappointing, because the data really do say even 10% of extra calories from added sugar is just too much. It really is about 6% where you start to see changes in chronic disease risk and inflammation and some of the other risk factors. Okay, I'll turn it over to Kristen for this slide.
Okay, all right, there's a lot going on here. And so we have a couple different stories to tell, and the numbers kind of go a little bit sideways. So I imagine what our brains first do is maybe try to go, what's that big thing? What are those big bars? And those big bars represent the benefit bump, the increased CVB value. So it meant that every WIC participant for the summer got $35 to spend on fresh fruits or frozen fruits or canned fruits and vegetables. And so all of these bars are representing the total amount spent, or actually, wait a minute, I didn't make this one, so I'm going to turn my head to the side. It's the amount issued, and then these orangey colored ones are the amount spent. So we were around $400,000 a month, and then it bumped up to about $1.5 million per month while we had that increase. And now with the current Academy's advice, I think it's, and I'm sure someone could correct me, it's $47 for pregnant and lactating women, $43 for our postpartum participants, and $24 for children, I think. And so we're seeing about $1 million spent. So this is incredible. We are seeing, because of this benefit bump, we were able to see an increase of about 500 new fruits and vegetable types. It's meant not just more, but a greater variety. It is, of course, a really versatile benefit. But then there's another story, of course, we see, and that is that red line. That's the utilization. Utilization rates have been declining for a while. We know that, and they've been declining across the board. But fruits and vegetables have been one of the most popular benefits. So we were a bit surprised, or at least I was, to see that even with this benefit bump, we still saw this kind of slow, steady decline. And I have actually pulled the last 5 years of data, and it had hovered around the mid 80s. And then really, I think it was in April of 2020 is when we started seeing the dip. And so we've been from mid 70s to low 70s to, as you're seeing right now, upper 60s in terms of the percent of benefits that are being utilized. So we have one story we can tell, which is we have many more vegetables and fruits being consumed. We have more variety being consumed in hopefully improved diets. And yet at the same time, participants are still potentially facing barriers in redeeming the full value of their benefits.
Thanks. Kristen, did you have anything else to add?
I mean, I could geek out on this for a while, but they know where to find me, so.
Okay, great. I know the feeling. I could talk about this kind of stuff all day. All right, so that's, oh, you have another slide.
Oh, I think this is just looking at the increase, and these were 2 different time periods trying to capture. We added canned. We had prior to the kickoff of the pandemic, we had not included canned. We just had fresh and frozen. So this was trying to compare 2 years of data as we were trying to figure out what was going on. With the summer data, we now have even more, but this is just showing, hey, we purchased many more different types of fruits and vegetables based on these 2 different time periods, and we've compared other time periods since. So it's just, again, focusing on the variety. But I will share the top 5 are consistently the top 5, and that is really serving our population of 2 to 5-year-olds. That is bananas, tomatoes, avocados, strawberries, and grapes. Pretty popular with the toddler set and available year-round.
All right, thank you. All right, so we're going to take about, let's see, do we have maybe about 10, well, maybe about 8 minutes, and go into breakout rooms for a little discussion. Just kind of with the data that was just shared, what surprised you, if anything? What types of counseling topics or messages came to mind when you started thinking about the data on, say, food group intake compared to recommendations? Whether there's a need to change any of the messages that we're currently providing to clients. And then if you have any thoughts or about the reasons that we're seeing the changes in the CVB redemption. So I'm going to stop sharing, and Laura or Cheryl, are you going to do the breakout rooms or? Okay.
Yes, if I can get unmuted. Yes, I have them all ready to go. Before we move, just wanted to give a minute if anyone had any questions for Jamie or Kristen on the data that was shared. You can unmute or put them in the chat.
Okay, I did see one in the chat about dairy, including cheese and yogurt.
That's right.
Yes, it does include things like cheese, cottage cheese, and yogurt, and it includes any of the soy substitutes for those, like soy yogurt, but it doesn't include any of the like coconut yogurt or the cashew yogurt or any of those kinds of products.
All right, I'm not seeing any other questions come in. I think we'll have some time at the end if additional things come up or things come up in your discussions.
Right. Laura, can you see my screen?
I can, yeah. And actually, Jamie, I didn't know if we want to give a minute or two for people to share anything from their conversations.
Yep, we can do that.
Yeah, so if anyone has anything from their conversations they want to share, feel free to unmute, put it in the chat, raise your hand.
So this is Mandy from Baker County. One of the things that I mentioned is with that increase in fruit and vegetables, we also saw a lot of increase in SNAP benefits and other help. So I find a lot of my families aren't really utilizing their WIC, even the ones that love WIC and they're not going to give it up, but they're not using their benefits as much because their SNAP benefits are going so much further. And if you can run the one card, why run both or worry about specifics with WIC? So I don't know if that's part of why people aren't spending as much of those fruits and veggie benefits, just because they're not spending WIC benefits.
So, and this is Jill in Clackamas. That was a conversation that we had in our group as well, was that the increase in the SNAP benefits was impacting the redemption at a lower rate. But what we talked about was, encouraging families to run their WIC card first before they kind of be proactive in that messaging of, do your WIC card first and then run your SNAP card. But definitely seeing the same sort of thing.
And it would definitely be interesting that now that a lot of those extra benefits have gone back down, if we do get an extension on that increase in fruits and veggies, if we actually see it go up like we would have expected in the first place without the counterbalance.
Are there any other thoughts or questions?
I was just wondering, with the WIC Shopper app, is there a way for a banner on the WIC Shopper app say, please make sure you use your WIC benefits prior to using the SNAP benefits?
Yeah, we could always do a little remember to run your WIC card first, but they've got to be opening their WIC Shopper app in order to see the banner. So they're probably already shopping with their WIC, but it's certainly a good reminder. Yeah, thanks.
And I think with our group, we talked about during the pandemic, our WIC participants are not able to do curbside pickup like the SNAP participants. And I think that caused quite a bit of problems as far as not being able to use their WIC benefits, or, perhaps dropping our caseload because they feel like they're not able to use it.
I think that's a great perspective too. I know for myself, if I can avoid going in the store, I do. I'm sure moms with extra little people to pack around the store are probably feeling the same way.
I have a
Anything-
2-year-old, and yes, it's curbside as much as possible. Yep.
Anything else people wanted to share from their breakout rooms?
We touched briefly on thinking of vegetables. I described it not as a monolith, but when we talked to participants, thinking about them as the kind of different color groups, and that's maybe one way to talk about variety. And my audio cut out a bit, but I think the group also talked a little bit about how sometimes they use feeding and with vegetables and colors as a bit of a developmental tool as well. So I can't speak exactly to that, but certainly an interesting way to engage.
Any other suggestions, comments? Okay, hearing none, I will go back to sharing my screen and let's talk a little bit more about this then. Okay, so I'm going to talk just a little bit about the category sources of energy in food groups. And this is data that actually does not appear in the scientific report. It's the background data that we ran as we were making our recommendations. And it actually is publicly available. It's really down a big rabbit hole on the USDA website. I will say, so what this does, just to kind of orient you to the slides, each of the colors on these bars are different macro, sort of the large food group sources that provide that food component or that nutrient. And what it does by doing this, we were able to kind of see shifts in sources, like which ones stayed consistent across the lifespan, which ones changed quite a bit. I have put a blue arrow by the 2 to 5-year-olds just to kind of draw your attention there. I will say that we did not have data for pregnant and lactating women specifically for this, so I wasn't able to include them on the slide. But one of the biggest things, so when you look at sources of energy in the diets of 2 to 5-year-olds, what you will see is the largest source is actually higher fat milk and yogurt. It's burgers and sandwiches, which also includes things like tacos and burritos, and it's desserts and sweet snacks. And you see some pretty consistent, with the exception of the dairy, most of the food sources of energy as a proportion of your calories stay pretty consistent across the lifespan. So this really does tell us that the habits that we set up at 2 to 5 years of age really do tend to track, at least when it comes to energy, across the lifespan. When you look at vegetables, what you see is that the mean vegetable intakes do increase with age. But again, at no point do we meet the recommendations. About half of the vegetables are eaten as what we would be able to identify as a vegetable, like a carrot stick or a spear of broccoli. The rest of it is pretty much going to be on sandwiches or burgers or tacos or burritos. It's going to be put into something like a casserole or other dish, or it's going to be baked into things like chips and crackers and savory snacks. The eggs, everybody asks about the eggs. That's actually omelets. So that was a source of vegetables as well. But you can see that for the 2 to 5-year-old children, starchy vegetables are their largest category. We see mixed dishes like meat, poultry, seafood dishes, and then beans and vegetables also as significant sources. When you look at fruit, the fruit intake decreases starting at actually at about age 3 and continues to go down. 100% fruit juice intake decreases after adolescence. So it stays relatively high compared to other points in life. And then in adolescence, they start to substitute things like energy drinks and soft drinks. And then later in life, the fruit juice pretty much goes. But not as much. You can see here that fruit, the blue bar is the non-juice fruit. And so actually that is a larger proportion of fruit than the fruit juice is across the lifespan. When you look at whole grains, what you see is breakfast cereals and bars really are consistently the highest source of whole grains. Burgers and sandwiches are going to be second. And then, as I said, things like chips and crackers and savory snacks are up there at number 3. When you look at dairy, we see that higher fat milk and yogurt is the biggest component for young children. As children age, cheese becomes a larger percentage of their source of dairy. And that's either cheese in and of itself or on things like burgers and sandwiches. And then when you look at protein foods, what you see is that protein foods, for the most part, are going to remain relatively stable. We see that for older children and younger adults, burgers and sandwiches are their main food category source for protein. For children, we do see the one thing that's a little bit different for kids then is that sort of burgundy colored bar at the top, or rust colored bar, and that's deli meats. So we see a relatively large proportion, I think more so than any other period in life, of deli meats and cured meats. Now, we didn't, as I said, get to look at this among pregnant women, but we did continue to have those reservations about the use of cured meats or deli meats if they're not heated and not cooked, because of things like salmonella and other potential foodborne illnesses in pregnant women. Then when you look at added sugars, you can see that sugar sweetened diet beverages aren't quite as high in the 2 to 5-year-olds as they are later in life. We see desserts and sweet snacks a little bit more frequently in the children than we do in adults till they get into their 70s. And then we see a lot of ice cream. For some reason, 70-year-olds just eat a lot of ice cream. But one of the things that I think is important to note is that starting by age 6, sweetened beverages become the largest contributor of added sugars to the diet of young people. And it says sugar sweetened and diet beverages, and it's just odd that they put diet and sugar sweetened together, but that's just the way that those food categories, we wanted them separated out, but you can't do that because of the way they collect the data. So that gives you a little bit of an idea. When in doubt, we had a kind of a joke on our food pattern modeling subcommittee that if other than fruit, if you ever needed to give a good guess as to what the top source of something was, it was probably burgers and sandwiches, because literally for everything but fruit, they were one of the top 3 sources. And for things like energy and protein and some of the others, they're often the top source. And so one of the discussions we had about, what do you do then to increase fruit and vegetable intake, particularly vegetable intake, if burgers and sandwiches are going to continue to be such a large component of the food that children and adolescents and even adults eat? Maybe rather than getting people to try to eat all their vegetables on a plate, it might be, how do we think about building better sandwiches and burgers? And how do we think about mixed dishes and things that can get the vegetables in to the diet in a way that people are already eating, rather than asking them to make some changes to how they eat vegetables, which may or may not be as welcome to them. So I'm going to switch for a little bit and talk about how we figure out what the nutrients of public health concern are. So interestingly, sort of unbeknownst to me, I didn't realize that in all of the dietary guidelines committees, there has never been a consistent way to do this. So we actually have a paper in, I think it's already been published, about what we recommend that the dietary guidelines use going forward. And that is looking at intakes in the diet, whether there are biological endpoints. So if we took iron, for example, looking at iron intake in the diet, the biological endpoints, which are things like hemoglobin or hematocrit, and then what are the health consequences of having too much or not enough. And I won't go through this, this diagram, but it's basically all three of those pieces looking at whether or not we have those and then deciding whether or not something is likely to be a public health concern, whether it's something that might be a concern, but we don't have enough data, and so we consider it to be of special interest, or whether or not it's something we really don't need to worry about. So just for your own reference, as you read literature or you hear speakers, an underconsumed nutrient or food component means that it's underconsumed by 5% or more of the population. And in our case, sometimes we looked at specific groups like pregnant women, lactating women, or children under the age of 2. Overconsumed nutrients or food components are those that are overconsumed, so above the upper limit by 5% or more of the population from diet alone. A nutrient or food component of public health concern is one of those that met all three of those. So we have change in dietary intake that's not recommended. We have some kind of a marker, whether it be like hematocrit or hemoglobin, where you can measure status. And we have a health outcome like anemia, which results from that deficiency. And then those nutrients or food components that have a special challenge, those are the ones where we think that there probably is concern, but we don't have enough data to bring it up to a nutrient of public health concern. So this is data that we ran on pregnant, lactating, and not pregnant and not lactating women. And it's the first time we had ever really pulled these data out to look specifically at women and of all three reproductive statuses. And what you can see is if, let's say you use the 50% range, just because that's an easy one, so right down the middle, the nutrients where we see women having intakes below 50% of what they should are vitamin E, vitamin D, and vitamin C. So those are, of all of the nutrients, probably the three that were the largest concern. For lactating women, vitamin C was relatively low. Magnesium was one of those that there really isn't as much data on magnesium as there are for some of the other nutrients, but the data are showing a trend toward a larger and larger number of women, both pregnant and lactating, that are not, pregnant and not pregnant, not lactating, that are not meeting magnesium recommendations. So that's one that we suggested an eye be kept on. And then vitamin A is also one that we're seeing creeping up. Again, if you remember back to the data, red and orange vegetables were the lowest in terms of meeting the recommendation for both the general population of women as well as pregnant and lactating women. So we put all the nutrients together and we took a look at them, and I put in red the ones that were of most concern. So for pregnant women, which is the green column, calcium, you can see that about 25% of women did not meet calcium intake from food alone. And even when they're taking supplements, it was still 17% did not meet it. Folate, you can see, was a big concern. There's magnesium, really interesting nutrient, and one that I think we need to pay a little bit more attention to in pregnancy. Iron, 84% of women were not getting enough iron from foods alone. And even with supplements, it was still 36% that were not getting enough iron intake. Vitamin D, Again, not many sources of vitamin D in the diet, aside from some egg yolks and maybe some irradiated mushrooms, which I don't know who eats those, but apparently they're a good source of vitamin D, I found out. 96% of women are not going to get enough vitamin D in their diets, largely because of that low dairy intake. And even with supplements, 38% are still not getting enough. Choline and potassium are some nutrients that were of potential concern of being maybe above the adequate intake. But again, not that they rose to a significant public health issue. When it comes to lactating women, vitamin D was by far the nutrient that was the most problematic. Most of the other ones, vitamin C, as I said, was an interesting one because lactating women had a much lower vitamin C intake than pregnant women. And the question was, is that actual data, or it was hard to imagine why that was going on. What would it be that had vitamin C that would have dropped out of the diet between pregnancy and lactation? So that's just kind of an interesting thing that I think left us all a little puzzled, and it is interesting to look at for future committees. And then potassium intake again in lactation. Then when you look at above the tolerable intake, so folic acid, there were a small number, but potentially significant number who were getting a lot of folic acid intake. And with the supplements, like 27% of them had high intake. Again, we looked at that with caution because these could be women who had a history of neural tube defects and were taking higher folic acid levels by prescription and not just for a non-medical reason. And then with lactating women, you see, again, folic acid and iron. This was problematic, and it's been one of the more interesting, I wouldn't say controversies necessarily, but there was a very strong consensus among the committee in lactation that women should not continue to take their prenatal vitamins after pregnancy because the iron levels are so high that up to 29 to 30% of women were getting really high intakes of iron. Yes, there is a need to replenish iron after a pregnancy, but there's also some concerns that when you have high levels of iron like that, it decreases the absorption. It can interfere with the absorption of other minerals, things like zinc and calcium and other nutrients. And so really was this concern and this push that maybe women finish out the single bottle of whatever they have left of their prenatals, but that they not take a prenatal supplement long-term after they have given birth. And actually, one of the questions we had is, why aren't there lactation-specific supplements for women that would have the other nutrients that we want to see, but more moderate levels of iron? And then sodium is just high in both pregnant and lactating women. And that's just the general population as a whole. So when we sort of take all that data and put it together in pregnancy and lactation, we're very interested and concerned about low iron intake in pregnancy, folate and folic acid maybe being inadequate in pregnancy, with a few women having very high intakes. Iodine, choline, and magnesium are nutrients we really need to give some thought to and maybe think a little bit more about what do we know about the science, try to get that science a little bit stronger so that we can make better recommendations for women. And then for all women, vitamin D, calcium, fiber, potassium, sodium, added sugars, and saturated fat were all nutrients of public health concern. We did look at this in infants, and one of the things that we were very cognizant of is that human milk-fed infants would have different sources than formula-fed infants. And so we actually, if you look on the right, all infants, you see that about 7% have low protein intakes. But when you actually examine by human milk versus formula, you see that about 27% of human milk-fed infants have lower intakes of protein, whereas it's less than 3% of formula-fed infants. We see, again, some big differences within iron. About 77% of human milk-fed infants have inadequate iron intakes, whereas it's about 7% for formula-fed infants. Now, I will say in this case, formula-fed is getting any formula, whereas human milk-fed infants were exclusively human milk-fed. And so that's why you see that 7% of formula-fed infants not getting enough iron, because they either were getting a significant amount of human milk, or they may have been getting other types of formula, like a low iron formula. And then zinc, we saw about half of human milk-fed infants having low zinc intakes, where it was less than 3% of formula-fed infants. What was relatively interesting, and I think a little surprising to many of us, is when we look at iron above the upper intake, we didn't expect to find a large number of infants with high iron intake. What we did expect to find, though, was that 77% of formula-fed infants may actually have zinc intakes that are elevated above the upper limit. What that means in terms of functional outcomes or potential issues, maybe with iron absorption or something else, really, we didn't have time to get into that. But there is this concern that zinc may be relatively high in formula-fed infants. And so it's something that I think we need to think about going forward in terms of what we recommend for solid foods then in infants that are getting human milk versus formula as a source of their milk feeding. So within the young children, the proposed nutrients or foods of public health concern were potassium, fiber, vitamin D, sodium, and added sugars. There were concerns about both choline and linoleic acid, but we didn't have enough data to really make strong recommendations for that. And then there was this concern that many one-year-olds may exceed recommendations for zinc and retinol from foods alone, especially if they're still getting some form of formula. So after all the science that we went through, and we put out an 840-some page report, what came out of that was the Dietary Guidelines for Americans. And I'll just focus on the pieces specific to pediatrics here. Number one was follow a healthy dietary pattern at every life stage. And within this chapter, it breaks it down by age. I think the things that are most important here is that in the first 6 months of life, we reiterated the push to exclusively feed infants human milk and to provide infants with a supplemental vitamin D source soon after birth, because those vitamin D intakes were so low in virtually almost all of the infants. At about 6 months of age, to start introducing the nutrient-dense complementary foods. Probably one of the most controversial of our recommendations was to introduce potentially allergenic foods along with other complementary foods. And there is an entire, there's the piece that's in the dietary guidelines. There's also the scientific report, which has literally, I want to say like 5 or 6, maybe even 7 pages just on this topic alone of the science that we reviewed and why we came out with this recommendation. And then to include foods rich in iron and zinc, particularly for the infants fed human milk. For those 12 months and older, following a healthy dietary pattern was important to achieve a healthy body weight and reduce chronic disease risk. Now, when we looked at the guidelines, one of the pieces that we felt had been missing in previous dietary guidelines was this discussion of the fact that the dietary guidelines are a framework. We don't actually have a diet within there, but it's a framework that you use, and you take your personal preferences and your religious and cultural traditions, You take your budgetary considerations, any other dietary restrictions you might have, and you apply those to that framework to come up with the right diet that is working for you and your family. And so it really is meant to not just fit the food. They may use examples in some of the dietary guidelines documents for specific foods, but it's really, those are just examples. It's really meant to be applied broadly. And so one of the things to keep in mind too is that the dietary guidelines are meant for populations. So we don't get into some of the things like, what do you do if you have milk allergy or you have egg allergy or whatever? That is something that's meant to be done on an individual level. And so we didn't address those kind of individual pieces. We tended to address more broad-based questions. We did look at developing food patterns for the birth to 24-month-old age groups. And the first thing when you do this was something that I don't think any of us had done before. We needed to look at the energy levels across this age group. And we ended up with 5 energy levels that started at 600 calories and went up to 1,000 calories as our reference calorie intakes. Then we had to figure out what were our nutritional goals. And so we did energy, the macronutrients, we did 3 fatty acids, 12 vitamins, and 9 minerals. Then we had to look at what data was available already in the food groups and the subgroups that the USDA had available. And where things got really hairy was trying to figure out what to do with those 6 to 12-month-olds, because some were getting human milk, some were getting infant formula, and some were getting any combination of those two. And there was no way we could possibly model all the different, like a quarter of the milk-fed calories coming from human milk and 3/4 from infant formula, half and half. It just got to be too much. We did end up modeling human milk at 3 levels then, what we considered low intake, average intake, and high intake. And then at each of the 3 age intervals to try to capture amount of human milk or formula they might be getting. So 6 to 9 months, 9 to 12, and 12 to 24 months. And then those energy levels. We looked at the patterns that were existing, and I won't go through all of this, but it was really, how did we figure out how much of each food group would be in those patterns? We looked at different kinds of nutrient profiles. Again, this is probably more detailed than you know, but the one thing that's important to note here is when we looked at the dairy group, we used typically in the adult dietary patterns, they would use skim milk. We did not use that because that was not in line with the under 24 month of age. So we used the appropriate milk category there. And then we had to model all of these, and pretty soon we had literally hundreds and hundreds of different potential calorie, human milk fed, nutrient profile diets. So we were not able to establish a recommended food pattern for those 6 to 12-month-olds because that human milk versus formula versus complementary food combination just ballooned out of control. So there was some work done. They're still building on that. It is an ongoing process, but that food pattern did not actually come out. So there are some examples of how you could do it. And this is one of those examples that we came up with. Again, it's not a final pattern. And this is available in the dietary guidelines. Now, when you actually look at the food patterns that did come out for the 12 to 24-month-olds, what you will see is that, they look pretty much like almost any other. You have the same kinds of categories that you have. Where we ran into a little bit of issue is there was really no way to get a completely perfect pattern, and you don't necessarily get that in adults either. But this is, so we ended up with one food pattern for 12 to 24-month-olds that did not include any human milk or infant formula. So this was an assumption that children had fully transitioned to table food and beverage. What we did, I noted 4 things here that I think you should keep in mind. Anytime there's less than 75% of the nutrient that is provided, it gets a little bit concerning. So you can see that there's the potential issue here for, let's say we've got potassium. There was a potential issue with zinc where it's really high. We've got 220 to 240% of the zinc intake. Vitamin D was relatively low. Only the 1,000-calorie pattern were we able to get up to 75% or more of the RDA. Everything else was low. So they really are considering, the importance of those vitamin D supplements in there. So there is a pattern for, that's kind of the healthy US pattern for infants who have both, animal and protein, animal protein and plant-based protein sources. We did model a lacto-ovo diet for infants. We were not able to do a vegan diet for infants. We did have to have 3 eggs per week in order to get enough choline. And this is what it looks like. It is available in that scientific report if you're interested in a lacto-ovo pattern for those 12 to 24-month-olds. And then I already talked about the sugar issue for adults. What I will say is that there is literally less than 3 grams per day of room for sugar in the diets of children. And so the recommendation is absolutely no added sugar, because 3 grams per day is less than a teaspoon. So there's really no way to model that in there in an appropriate way. All right, so it's time for our next sharing if we have time. And again, it's very similar questions. What information was new to you? What are key changes and recommendations that you might think about after hearing this information, and what resources would be important to have? So Laura, I will turn it back over to you. Do we have time for breakouts?
We definitely do. And we had a couple questions that came in while you were presenting, so I'll bring those up, and feel free to add more in the chat if you have questions. So these questions came in when you were talking about the food categories, and just wondering, do deli meats include hot dogs?
Yes, they do.
And then do sugar sweetened beverages include like energy drinks and Body Armor, which I think is a sports drink?
Yeah, so it includes the energy drinks, the sports drinks, it includes lemonades, fruit aids, anything with added sugar that's not 100% fruit juice.
All right, I think that was all the questions I saw. So we'll go to our breakout rooms. So yeah, we're just going to kind of wrap up so we can start with anything that came up in your discussions that you wanted to share.
Jamie, I'll speak for our group, and the others can chime in, but we are concerned about the recommendations for sugar, that it really, the added sugars, it seems unrealistic, and that it, how do we frame that so that we don't, shame or blame our participants? And then on the flip side of that, does WIC kind of contribute to that added sugar, or on a different area, kind of contribute to setting up drinking your fruit juice, and the role of juice in WIC for setting them up for sugar sweetened beverages later after, that age group of 6 years of age. So what has been the feedback on the recommendation for the added sugar as you've had these presentations?
Yeah, so I think there's been a number of people on both sides of the aisle. There were people who really felt it was unrealistic. there were other people who said that's great because if you can get children starting out eating less highly sweetened foods, then they won't develop as much preference for sweet foods. And so over the lifespan, it may be beneficial. And I really think what it really comes down to is it's the added sugar piece. So it's not that children can't have anything sweet like juice or whatever. But, you know, I think when you look at the WIC cereals that are approved, things like Cheerios, they're all low sugar options. So within programs and policies, really making sure that what we promote and what we provide are those healthier options. I don't think we're ever just our food system being what it is. It's really hard, even for an adult, to pick a diet that's less than 6% of calories from sugar, much less no added sugar. But a few changes like sugar, if you took out, we did a little bit of modeling. Actually, we didn't do it with the youngest kids. We did it with older kids and with adolescents. And if you took out just one serving of sugar sweetened drink and one dessert every day, you'd have enough calories to add in to meet all your dairy requirements, all your fruit and vegetable requirements, and I think still have a snack somewhere in there. So there are, I think, the big things like cutting down on sugar sweetened beverages, cutting down on desserts, that can go a long way toward reducing that sugar intake without having to feel like there's nothing that we can give our kids to have. I think in terms of juice, you know, and this is just my personal take, but there's juice and juice. Like apple juice tastes like sugar water. It may be apple juice, but it's very, very, very sweet. Orange, citrus juice, tomato juice, things like that don't taste as sweet. And whether or not, you know, there's some room for us to really be changing what we offer children within that framework. There's also more nutrients in some juices than others. So I think you can make choices within the juice category without having to get rid of it. But I also believe that, you know, many cultures don't have juice. They eat the solid fruit and drink water. And that that might, for some children who have other sources of sugar in their diet, that might be the trade-off that you make then. I don't have all the answers, but those are the kinds of things we're getting feedback from and what we're hearing. Yeah, and I like the comment that apple juice is made of like 50 apples. So, you know, you have to, there's juice and there's juice. Other questions, comments? This is really more for you to share, I think, and discuss than just for me to talk all the time.
In our group, we talked about maybe in terms of a resource need, maybe what to feed formula-fed babies, you know, in terms of complementary foods versus breastfed babies, helping to have more of a distinction between, you know, one versus the other versus something more general.
And really promoting more of the, are you thinking the zinc and iron and the for babies getting human milk compared to formula?
Exactly. Yeah, to introduce the meats earlier. Mm-hmm. I was just curious, Jamie, if your group talked at all about carbon footprint and, you know, with climate change, and it was a little shocking to hear how much burgers and sandwiches are part of our culture.
Yeah. So we tried very unsuccessfully. So what they did this time around, and I understand it'll be this way going forward, instead of allowing the committee to come up with their own questions, we were given questions that we could answer, and we were not allowed to come up with any questions or deviate from those questions at all. And part of that was in response to the previous dietary guidelines who had started talking about climate change and plant-based diets, and that was just totally cut down and cut out. So they, believe it or not, last week, Friday, they had their first internal meetings to start the process for the 2025 dietary guidelines. I would guess within a year or so, they're going to start putting out the public comment periods. And one of the things I would encourage you to do, either as an individual or as part of a WIC association, is to really, if that's important to you, keep putting those comments out there as this needs to be included, because they have to read those and they have to publish those. And if 60% of the comments are pushing for that, it's going to be really hard for them to not address that. So believe me, I've got my letter writing all ready to go, because I'm going to be really pushing, I think, the need to at least address that as a consideration of part of a healthy diet, that it's not just health for the body, but it's health for the planet and the community as well. So yeah, that is something we need. And, you know, and we've got the lacto-ovo diet. We've got, we do not have a vegan pattern for adults. And there is somebody at the USDA Human Research Lab in Grand Forks who's actually trying to put something together for adults and trying to encourage them to come out with a vegan pattern as well. Again, I don't know how much traction that's going to get, but you know, just putting those ideas out there and keeping them at the top of that list of comments is how you get things changed and get them included in the dietary guidelines. Yeah, and I see Cheryl's comment about the alternative milks, and that is something that, boy, there was so much pointing to that, and we weren't allowed to look at it because it wasn't on our list of questions. And quite frankly, they didn't have as much data going back to 2016 as they will have when they do the next round of dietary guidelines.
Earlier, I wanted to bring up that we had talked about another change from what we have been counseling is in regards to, you know, not offering juice until 2. That would be a really big change in terms of the messaging we ordinarily give. And then also with the grains going down, it was brought up in my group about talking about grains, and someone brought up that she's that sometimes people are on a keto diet and then they try to give that to their kids, you know, which, and so how that the keto diet has kind of affected the intake of grains in some participants.
Yeah, I've heard people talk about how their children, watching other children eat carbohydrates and basically shaming the mom for feeding them that. And there's really nothing wrong with a good carbohydrate, especially when it's whole grain. And so yeah, that
they're good for you.
yeah, there's more balanced messaging. And the same, you know, starchy vegetables is the other one. I remember somebody on our committee who was a physician saying, why do we even have that there? You should be eating starchy vegetables. Well, there's nothing wrong with a starchy vegetable in moderation as part of a healthy diet. Like, I personally like potatoes, and I can't imagine Thanksgiving without a good mashed potato. But, you know, I think things can be taken to the extreme, but that's what it's all about, is putting things into context and really letting people enjoy food, but also, you know, you can enjoy food in moderation and make some healthier choices within that. Should juice be included in the next dietary guidelines? That is something that because juice is one of the categories of fruit intake, I'm guessing it will always be a consideration in there just by, unless they change the way that they categorize the food when we look at all that data to make the dietary patterns, fruit and fruit juice just get lumped together. They don't separate them out. So if they change the methodology of how the data get to the committee, I think the committee could look at them differently, but I don't think we could otherwise. The other thing I'll say that your comment made me think about was probably the number one public comment we got, aside from either you shouldn't have any meat at all or you should be on a keto diet, was a lot of people saying that we should not have dairy as a food category, that it didn't belong there. And that is, there's like this big anti-dairy push. I, again, don't see dairy going anywhere. I think it's going to stay part of a category. I wouldn't at all be surprised to see if the soy milk and other components in there continue to become a larger and larger component of that category, though.
Did you say, Jamie, I believe I heard that for pregnant and lactating women, or maybe women in general, they're 50% below on vitamin C?
It's lactating women only. So pregnant and non-pregnant, non-lactating women tend to do okay with vitamin C, but there's something about lactation where like the number of women getting inadequate intake jumps up. And we weren't sure if that was just some kind of weird thing that happened in the data or if that was real, because it's never been looked at before. So we didn't have any historical data to compare it to.
Because if juice goes away, that will definitely be something, you know, in terms of like other sources of vitamin C and talking about that.
Yeah. And, you know, for pregnant women, we always encourage them to drink a lot. So you would think that, that's why we were trying to figure out what is it? Why is vitamin C going down? Are they not drinking something? Are they not eating something?
It was suggested in the chat that maybe the vitamin C dropped for lactating women because of the GI upset that was caused in the infants. So they may have cut back because it was seen to be bothering their infants. And that was from Kathleen in Warm Springs.
Yeah, we didn't have any data on that. So that would be interesting to know if that's happening for the committee to know that if we see this again, when they run the data the next time, that we continue to see this vitamin C difference.
Any other questions for Dr. Stang?
You have my email and you have the slides, so you can, feel free to share whatever you would like.
Okay. Thank you so much, Dr. Stang. This has been really interactive and it feels like you made the dietary guidelines more approachable, that many of us have heard other presentations, but just being able to have it specific to Oregon has been really great. And thank you so much for taking this time to do this and for the connection you have with Laura. So.
Thank you, and feel free to email me if you have more questions.
Great. So we do have Dr. Stang's email, and then the next step will be we'll be sending out a feedback survey, and that information that we want from you as the local agency dietitians is to be able to help inform the in-service of packaging this all up for a quarterly in-service that can be shared out to all local agency staff, and that would be coming. Be developed and posted by early April with a completion date by the end of the year. Laura has put the survey link in the chat, and so you can link to it directly after this through this presentation or in the email. And we just want to thank you for participating today. And the next presentation will be in May 6th. So another unusual day. That'll be a Friday. So we'll test that out. And we will be looking into anemia. So the discussion and the controversy about iron will continue at that time. So that will be coming up. So thank you all and have a wonderful afternoon. And it's what, 6 o'clock your time, Jamie?
Yep.
Yeah, so thank you for
Time
letting
for
us
dinner.
go into your evening hour. All
Okay.
right, thanks so
Bye.
much. And thank you, Kristen, for your contribution and Laura for making all the connections. So we'll sign off.